Hello, everyone, and welcome to today's ESCR educational webinar on congenital heart disease. I'm Professor François Pontana from Lille, France, and I'm honored to be moderating this webinar alongside with two highly experienced lecturers, Dr. Daniel Devos from Ghent, Belgium, and Dr. Aurelio Secinaro from Rome, Italy. So please feel free to submit your questions through the Q&A section, which I will address after each presentation. So it's now my pleasure to introduce Daniel Devos, radiologist at Ghent University Hospital, who will talk about aortic coarctation. Please, Daniel.
Thank you. I will start sharing my screen. Are you seeing my screen currently?
Yes.
Okay. So thank you for the opportunity to give a lecture here. I'll be talking about coarctation. These are my disclosures, and this is this evening's sponsor, to which our gratitude goes. I hope all of you have read the learning objectives, and that's the reason why you're listening. And I'm going to talk about coarctation. I've been looking in the Dutch language or in the English language for a word that sort of resembles coarctation, and I couldn't find it. So the Latin word coarcto means to draw together, to make tight. And that's what the actual lesion is. I didn't find any word closely resembling it, so coarctation seems to be quite a unique word for quite a unique lesion, actually. And there's two different coarctations that are being described: the preductal and the juxtaductal or postductal coarctation. And the preductal coarctation is the one that is mostly found in a young pediatric population in combination with complex heart defects. And the ones that survive that phase are the ones that have the postductal coarctation, and those patients seem to be to have a bicuspid aortic valve a bit more frequently than the normal population. There is a male preponderance, and it is one of the most frequent congenital heart lesions. There's several theories about the pathophysiology, and one of the elements is the ductus tissue theory, that some tissue that should be the ductal tissue is incorporated into the aortic wall. And so when the ductus arteriosus constricts after birth, it will also constrict part of the aorta. The argument that supports this part of the theory is that prostaglandin apparently is capable to relieve the obstruction of a coarctation. Another theory, another part of the pathophysiology is the hemodynamic one, where it is described that a decrease in blood flow through left ventricle or aorta, such as in a ventricular septal defect or an outflow obstruction or an hypoplasia of the arch, leads to respectively left ventricular hypoplasia or coarctation. And of course, there also is a genetic part to the entire problem, because of the notion that there's a high occurrence among relatives, and there are a few genetic syndromes with coarctation. Is it only the particular lesion that is the problem, or is there something else going on as well? And actually there is. It's not just the one stenosis, there's also systemic hypertension. There is an increased risk of myocardial infarction, and there are wall changes such as a decreased distensibility of the pre-stenotic aorta. And there is premature atherosclerosis. So actually, there is more going on than just the one stenosis. It is a systemic vascular disease. Now, we didn't plan any polling, but I give you 10 seconds to think. What would you think is the age of death in the natural history of untreated coarctation? The last 3 seconds to make your decision. It is very young. 31 years of age is the median age. This is the survival graph of people with coarctation that have survived the first year. So it's not the complex heart disease, it's the complex heart defects. It's the ones that have survived that first year. And in that group, you will see that a larger quarter of them have passed away by the age of 25 already. And that is due to aortic rupture, to bacterial endarteritis, and intracranial hemorrhage. The patients that survive those first 3 decades, well, they will die in their 30s due to cardiac failure. The treatment, of course, is surgery. It started off with end-to-end anastomosis, and then because of the need of some more extra tissue to make the actual lumen of the connection, there was a subclavian flap aortoplasty solution in which the subclavian artery was sacrificed, of course, and then much later the balloon and the stent solutions. This is a first example. This young boy had this end-to-end surgery at the age of 2 years old, and you can see now. So they did the follow-up for years, and only at the age of 9 years did they ask me to do this MR. You can see that there is a narrow segment that was. They left it like that for a few more years, and at the age of 15, this patient got the first stent. There was a stent, and only at the age of 20 did they need another imaging. So we do have a place in coarctation, but it's not like every year. It's only specific moments. It's not a very simple, straightforward procedure. It can go wrong. That's this one instance where I did see a dislodged stent. The diagnosis of coarctation is actually on a clinical basis, a pressure difference between arm and leg, and occasionally the cardiologist could be thinking of a bicuspid aortic valve and then ask us to look for, hey, is there coarctation as well? Or it could be that you as a radiologist find a coarctation and then you have to go find a bicuspid aortic valve. Of course, it's a spectrum, you all know. The easiest way to find a anatomical bicuspid aortic valve is by using the hammock sign. You scroll through the entire sinus of the aorta in a coronal plane, and then you will see this line. This line here is going to span the sinus all through this sinus. From back and forth, there is this line. You can call it the hammock sign. If you look at images perpendicular to the coaptation plane of the aorta, it looks like this, the whole sinus through. You could call this the bum sign, but that didn't make it through the review. Another example is this young adolescent with a coarctation, and if we turn this around, you see the extensive collaterals. If we turn this around, you find there's a pinpoint, very short coarctation, a high degree stenosis. You can see the same collaterals, arterial collaterals around the spine in the mediastinum and following underneath the ribs. And what happens if this patient gets this lesion stented? Look at that. all of the collaterals are gone. Even though, if you now look at the actual stent, I'll make the switch again there. If you look at the actual stent, it doesn't look like, oh, it is as wide as the rest of the aorta. Well, that's fine. This is a good repair of the coarctation. Another a little trick that can help you to find the location of the coarctation, to define the coarctation, is preductal or postductal, is go look for a calcification of the ductus arteriosus. That could help you. Notice that in this very young patient, there is a bovine arch, one common trunk for all of the arteries, subclavian and carotid arteries, which puts this patient in the box of higher risk of restenosis and higher risk of mortality. What do you think, another 10-second question, what do you think is the main focus of cardiological follow-up after successful coarctation repair? What do you think is recoarctation? We need to be sure of that. Is the cardiologist mainly going to look for hypertension, or is it coronary artery disease, cerebrovascular disease, or is it just the acute and dangerous things, aneurysm or rupture? What do you think? 3, 2, 1, it is hypertension. And what if the cardiologist sends you a patient with the friendly letters FU? What is he looking for? Well, it's anatomy. It's indeed recoarctation. But the definition of recoarctation, do you think that it is clinical? Do you think that it's ultrasound diagnosis? Do you think that it's a CT diagnosis where we can do this stenosis reduction diagnosis? Or is it an invasive measurement? Another 3 seconds to think about this. It is clinical. And you will see it a bit more often in balloon angioplasty, a bit more than in subclavian flap, than in surgery. And if you as a radiologist, you will find a coarctation within 1 year after the procedure, you should not call it recoarctation. You can call it residual coarctation. Another example. This is a male patient with a beautiful end-to-end anastomosis. It looks a tiny bit narrow. There is a jet indeed. There's more of a jet here because it's a bicuspid aortic valve. There is a bit of a jet that we can quantify, if I remember well, 228 centimeter per second velocity, peak velocity in this particular spot, which is a bit increased, but it's not enough to call it recoarctation. This is a good repair after successful repair. Another example, and this is the first female patient that I can show you. What's going on here? A functional bicuspid aortic valve, dilated ascending aorta, and a typical crenal-shaped aortic arch. This is the hallmarks of a Turner syndrome, and also there with MR we can go find the place where the peak velocity is, the velocity is peaking the highest to try and evaluate or estimate the degree of stenosis. This is a male patient with complex congenital heart defect, which has been treated. But I want to show you this one because, yeah, there's the coarctation is stented, but that let the stent not deter you from doing MR. Of course, there is going to be a signal void from the stent, but the actual jet you will see, and you will be capable to measure the peak velocity just below the stent. Now I want to show you this one, a young male patient with actually a nice result of coarctation repair. It is a dysmorphic aortic arch, a bit Gothic shape, yes, but there is a difference in blood pressure between left and right. And Whereas there's sort of a jet high up there, and there's a peak velocity. But I'd like to ask you, what do you think is the explanation of this lower blood pressure in the left arm? Is it a recoarctation? Would you dare to state that? Do you think it's the angular arch morphology, the Gothic arch, that makes this that's responsible for this blood pressure difference? Is it a Venturi effect, or is it just maybe the subclavian artery that's too narrow for that? Or do you think take the blood pressure again, measurement error? 3, 2, 1, what's your idea? I'm convinced, but I cannot prove. I'm convinced that it's a Venturi effect, and I want to show another example of that. Also, nice result of coarctation repair with the jet here. There you see it. This patient had a lower blood pressure in the left arm, but the blood pressure in the legs was same as the right arm. I think that there's actually a Venturi effect going on. I can't prove it, unfortunately. We can go down and see that there's coarctations also is possible in other places of the aorta. This female patient was diagnosed with a coarctation for the first time at the age of 57. And actually, we can't be sure if this is acquired or a congenital heart defect, unfortunately. But I have found an example of a congenital abdominal coarctation in, if I remember well, 80-year-old patient with extensive mesenteric artery collaterals. And there's one abdominal, one of very few abdominal coarctations that we are following in our institution. This is a narrow the coarctation of the abdominal aorta and the bypass that went in. And at some point we started to follow up every year because there was this this thrombus in the bypass. We're going to go a bit further on the spectrum of the aortic arch problems, and I want to show you an example of a very young patient. These images are annotated, these are not so, but they're the same. So you can follow, this is the descending aorta. We go up, we find a ventricular septum defect over there. We find a pulmonary trunk and a very narrow ascending aorta. That's descending, those are the pulmonary arteries. There's the pulmonary trunk, the bifurcation, and we can see very narrow aortic arch over there, which connects to the descending here. And in between, there's a ductus arteriosus. And I'll run through them again so you can now look at these images and find your way. So that's the descending, that's the VSD. Pulmonary trunk, very narrow aortic arch, and this is ductus arteriosus. And so there. What's this? This is the virtual rendering, the narrow aortic arch. This is pulmonary trunk and the very wide ductus arteriosus. And the solution for this patient has been to put a Sano shunt onto the pulmonary artery bifurcation, so that here the Norwood construction, pulmonary valve, pulmonary trunk, and ascending aorta can be put together into the Norwood construction. And then did they ask me to scan this patient at such an early age? Well, actually, because it's important for the surgeons to know if this trajectory from left ventricle to this pulmonary artery through the VSD, if that's long, then it might be a problem for the left ventricle in a biventricular repair. So that's what they want to estimate. Can they go to biventricular repair, or do they have to keep it like this? And then the last case I'm going to show you, it's the far end of the spectrum, aortic atresia. we'll look at a 3-day-old boy. In the coronal plane, we find the right and the left ventricle, and we find a pulmonary trunk, and a bit further, we see that there's, a VSD. This is the VSD. A bit further, we find the aorta, ascending aorta, which divides up in two carotid arteries, but there is no arch. And pulmonary trunk is very large. This is the right pulmonary artery, and a bit further there's a left pulmonary artery, and in the middle, in between, is the patent ductus arteriosus, which we can follow. There's a the right and the left pulmonary artery. Those are the subclavian arteries. This one comes off of the left pulmonary artery, and the subclavian artery is there on the right side. Branches off of the descending aorta. I'll run through them again so you can find your own way here on those images. Pulmonary trunk, aorta. Go find your way. This is the ascending aorta dividing up. There's no arch. There's a patent ductus arteriosus, which is so large that it sort of makes you think that it's the arch, but that's the confusing thing about the whole imaging in this patient. And there you go on to find the descending aorta. In 3D, it looks like this: pulmonary trunk, ascending aorta dividing up in two, very large patent ductus arteriosus. This is the right subclavian artery coming off of the descending, the left coming off of the pulmonary artery. And if we have a look here, what is actually missing? Well, we're missing the arch, aortic arch, and we're missing a subclavian artery. So that means that this branching off is actually a left patent ductus arteriosus. And it makes always sense to look if there is a vascular ring. Well, in this case, there is not. Complex cases, these ones, at the far ends of the spectrum of coarctation and aortic hypoplasia and atresia. So what I would like you to take away from this talk is the complex coarctation is associated with complex heart disease in the very young. Coarctation is associated with bicuspid aortic valve in adults. And what can we do? Well, mainly morphology and severity, but the actual diagnosis of recoarctation is clinical. I thank you for your attention. And I will now stop sharing there.
Thank you very much, Daniel, for this very comprehensive and well-illustrated presentation. So for the audience, please feel free to ask your question through the Q&A section. So maybe I will start with one question. How do you decide which patients should have a CT scan or an MR, or maybe both in some cases? How do you decide?
Oh, thanks for the question. In adults, I mostly do MR because of the option to do functional imaging, to measure the flow and give an idea of the grade of stenosis.
Okay.
In the young ones, it's in the very young ones, the neonates, it's mostly CT, just because it's so fast. And yes, there is the issue of dose, but in MR you would need the anesthesia, and so CT for the tiny ones, and then in between, like children age 5 to 10, you can actually choose, and the choice there is we do have a system in the house to train children for MR, and then you can, if that works, it works really well, and then you can do MR without anesthesia, and that's a plus. That's what we try to achieve. And if that's really not possible because the kids are not going to cooperate, then if it's really problem, then they're going to go to MR under anesthesia. And if they're sort of a problem for MR, well, but it's going to maybe work on CT, then we'll scan them on CT quickly.
Okay, and more minutes. Could you briefly outline your protocol for CT and MR in the context of aortic coarctation?
Oh, CT in adults is easy. You scan it as any thoracic angiogram. So we have the ROI in the descending aorta. We inject 70 ml is enough as fast as you can, and then you scan. That's easy. In kids, in babies, neonates, it's I inject the dose that I can give according to weight, and then it's just the heart has got to be full of contrast, and then we scan. There's not too much timing. Sometimes we use a ROI, but I quite often just put it outside of the patient, and I do the bolus tracking visually, and then we start, because the machine starts within 2 seconds. And on MR, it is always cines in long axis, always aortic valve, of course, a cine of the aortic arch, the candy cane view, and then phase contrast imaging on the jet, and then an twist angiography, like the keyhole imaging angiographic MRA.
Perfect, thank you. There is a question in the Q&A section. Should the angio CT examination protocol be modified in cases of suspected aortic coarctation? But I think you just answered this question.
I don't do anything special for the thing.
Perfect. Thank you very much, Daniel. So now it's time to move on to the second presentation. So it's now my pleasure to introduce Dr. Aurelio Secinaro from Rome. He will talk about imaging of cardiovascular shunts. He's an associate professor and the director of the Advanced Cardiothoracic Imaging Unit at Bambino Gesù Children's Hospital in Rome. Please, Aurelio.
Thanks so much. Good evening, everyone. I hope you see my presentation screen shared. And thanks again for ESCR and for inviting me for this webinar. I will immediately start by classifying congenital heart disease, just to make sure that everybody is aware of overview what's going on in our children. So the risk of having cardiovascular disease is low, but not so low for center congenital heart disease, in particular VSD and ASD. So it's very important to keep this in mind, because of course this is something we have to know, and especially in the follow-up and when we are doing our images. The other important thing is to highlight is that we have an increasing prevalence of congenital disease in our population due to the improvements in the treatment. So we will have an increase of scanning of these patients in the next few years. We're already seeing this in the adult congenital heart disease. So the GUCH population is increasing, and that is increasing the prevalence in the next years ahead. The other aspects in the diagnostic technique, we know that, of course, we have the change in paradigm in this setting, and that what is considered the echo first in line imaging technique is applicable, especially in neonates and in children in infancy. But well, CT is just as in the second line, so we use it that often to improve the quality and give anatomical information. But then MRI is becoming the gold standard in the youth and adult age. So those are the objectives of my presentation, and in particular I want to say that we will focus on type of defects and classification, some important clinical and pathophysiological aspects, and then we will understand how to measure and how to better address this case for management. So the most important thing about shunting is how to classify the shunting. So it's very important to keep this in mind. There are two main groups, so the intercardiac septal defects, and that is the one that is purely congenital related to the heart. But there are some associated extracardiac shunting causes, and those are, of course, represented by connection between large vessels, anomalous connection between large vessels. So, but then, what is the main way to measure and quantify shunting apart from the anatomical aspects? So, one is something that I want to stress, and that is not the daily routine for cardiovascular imaging people, is that we have to sometimes need to quantify the QPQS ratio. So this is QPQS is a ratio, is a number that is basically calculating very easily, that we can extrapolate from our MR especially. So the QS is represented by the effective blood flow that is going through the systemic vascular bed, and the QP is representing the effective blood volume that is going to the vascular bed, of the pulmonary vascular bed. So basically, whatever happens that brings blood flow going from left side to right side is sort of shunting, causing an increasing pulmonary blood flow, and whatever is going to the opposite is basically causing a deoxygenated blood flow going to the left side and then causing cyanosis. So how we can calculate this very easily. We know that from physics, from MR, we have the phase contrast velocity encoded images that we can plan in different different conditions and in different approaches. The mainly used is the through plane calculation or acquisition, and that we can apply into cross-cut, and so short axis views of the main great vessels in any part of the body, and in particular the great vessel. So in case of let's say increased pulmonary blood flow, and if we segment and calculate the phase contrast amount of blood flow in the cardiac cycle, we can of course make a proportion and differentiation between the blood flow going from the main pulmonary artery and the ascending aorta. That is in condition of left to right shunt, increasing the blood flow into the pulmonary artery, and give us a calculation of a QPQS that is higher than normal. In the normal condition, of course, this number should be 1. So the type of shunt can be classified also in, as we said, left to right and right to left, and they can produce, as we said, overflow and cyanosis. And based on this, we have different type of shunting condition. And today I will be focusing on 4 types of this condition, and which are, of course, the pre-tricuspid and post-tricuspid shunt, and then the cyanotic type, which are and the main one in this condition is the tetralogy of Fallon. So the pre-tricuspid left to right shunt that can happen in different anatomical conditions where there's a defect between the left atrium and the right atrium. In this situation, we have a normal direction of the blood going from the IVC and SVC into the main pulmonary artery, but we can have a diversion of the part of the blood flow coming from pulmonary veins into the main pulmonary artery. This will cause pulmonary overflow, right heart dilatation. That will involve, of course, the right atrium, right ventricle, and pulmonary arteries. Of course, this condition is mainly visible in a chest X-ray as an increase in pulmonary vascularity, as we can see similar infiltrates and increasing size of pulmonary vascular images at the hilum bilaterally. And of course, this is a main representation of pulmonary overflow. So the main cause of this shunting, as we saw from the epidemiology, is the presence of interarterial communication. We have different type of interarterial communication and different conditions and different incidents of these disorders. And of course, the main diagnostic technique to give this diagnosis is echocardiography. This is a 4-chamber view where we can have a a very good visualization of the shunting at the level of the interatrial septum, type 2 ostium secundum defects. And also we have some bicaval view that can be used to have another views for of the interatrial communication. But of course we can produce some nice images that are also give additional information from the anatomical point of view and dynamic point of view with MR of this ostium secundum ASD with and also we can also give a dimension of the margin of the rim and position of the defects, and also the direction of the flow with in-plane phase contrast angiography, and of course the additional information about the dilatation of the ventricles and additional information about kinesia of the interventricular septum. Of course, in the condition of the shunt, so at the level of the interatrial septum, we have increase in RV volume and atrial volume. And also we can, with the MRA, so angiography, evaluate the pulmonary veins to rule out the presence of congenital anomalies of pulmonary veins connection. For instance, this is a case where we couldn't find a proper interatrial septal defect with echocardiography and neither MRI, but we visualized the anomalous connection of the right upper pulmonary veins and sinus venosus cava superior defect that was causing right ventricular enlargement, a QPQS of 2, and a ratio between the two ventricles of 2.3. So this is the angiography showing the anomalous connection of the right upper pulmonary vein into the superior vena cava. So this is, as we said, configuring a PIPVD of the right upper pulmonary vein into the SVC with a sinus venosus ASD. This is another similar case where we have a cine images of the superior vena cava connection with a superior sinus venosus defect, and those are the images of the 3D evaluation of the pulmonary veins going into the SVC. Of course, a CT can be also used to identify these defects, as we see in these cases, and this is nowadays required for the anatomical planning of the treatment, transcatheter closure treatment of the sinus venosus defect in adult patients. So what are the main indications from ASD treatment? So from the guidelines, we can summarize this indication as follow. And basically the main aspects here is related by the RV dilatation, the presence of a QPQS that is above 1.5, and we have to consider the presence of pulmonary hypertension. The second type of shunt is a post-tricuspid left to right shunt. It is mainly represented by the presence of a ventricular septal defect of patent ductus arteriosus. In this condition, we have blood flow from the left ventricle going to the right ventricle, and this is causing again pulmonary overflow. But in this case, we have based opposite to the previous shunt type. We have a left ventricle and left atrium dilatation. So interventricular septum can have a very different type of anatomical definition, and based on this anatomical definition, we have different surgical interventional approach, and also we can have a different type of shunting, and this is of course very important to know that it's very important to have referring to the echocardiography first. This is a mid-muscular apical defect. This is a long axis view that is showing the classical perimembranous subaortic VSD. From the MR point of view, we can again quantify the QPQS with the phase contrast angiography, but we can also have the chance to visualize the defect, like in this case, we have a perimembranous subaortic VSD, or like other case, we can have blood flow and blood flow turbulences just below the pulmonary valve, and in certain conditions where the septal defect can be associated with the dual chambered right ventricle due to hypertrophied muscular bands. So this is again a phase contrast angiography in the cross-cut, so in the short axis of the ventricular septal defect. So in case, as we said, in case of a post-ventricular post-tricuspid shunt, like in this perimembranous VSD, we can beautifully quantify and visualize the left chamber dilatation, like in this case of shunting. And this is not a big, this is a restrictive VSD, but the blood flow in this case is significant. And this is a child during general anesthesia that was investigated for a mid-muscular large VSD. So this is another type that is localized just in the middle of the interventricular septum. So timing for treatments is very important in this patient because actually that depends on, in case of large VSD, on the QPQS ratio. If the VSD is restrictive, we can account the indication for surgery in a QPQS ratio that is above 1.5. In case of infundibulary VSD, so very close to the aortic margin and to the valvular level, the presence of aortic regurgitation is an indication for treatment. The third type of shunting type is the post-tricuspid right to left shunting that it occurs when there's a ventricular septal defect, but there's an increased afterload at the level of the RV that is usually related to a pulmonary trunk obstruction, and that is very common in tetralogy fallow patients. So again, we have the shunting at the level of the VSD is right to left due to the presence of an obstruction at the valvular subvalvular level. In this case, the clinical appearance of the patient is cyanotic, so we have a reduced flow in the pulmonary trunk, in the pulmonary artery, with an increased deoxygenated blood going to the aorta. This is a chest X-ray representation classical of tetralogy of Fallot, where we don't see there's hypovascularity bilaterally, and we don't clearly see the second arch on the left side, which is in keeping with the hypoplastic pulmonary arteries and pulmonary trunk. Tetralogy of Fallot is the most common cyanotic congenital disease. There is I don't want to go into details of the anatomical aspect. We will see that later in a CT. We have many variants, and we have some association with other congenital disorders and syndromes. Of course, in the preoperative assessment with CCT, cardiovascular CT and CMR is mainly towards the CT when echo is insufficient. We want to evaluate the pulmonary arteries, the lung perfusion, of course, other source of pulmonary blood flow, and particularly we can evaluate in this patient the presence of coronary anomalies. So this is a case of 12 days old newborns with the tetralogy of Fallot with the atrial septal defect, small. As you can see here, the pulmonary trunk and pulmonary arteries are mildly apoplastic. There is a subaortic ventricular septal defect malalignment with a large VSD at the level of the AV valve, so posteriorly enlarged. And in this case, we investigated the patient to clearly identify the anomalous coronary origin with the right coronary artery arising from the left coronary artery in the anterior descending and passing anterior to the pulmonary trunk. This is another case of the extreme tetralogy of Fallot patient with the pulmonary atresia, ventricular septal defect, and very tiny branch pulmonary arteries. And as you can see here, other source of pulmonary blood flow from the descending aorta and the aortic arch, in keeping with the major aortopulmonary collaterals. And these patients are going usually for a complex congenital heart repair. And this is the 3D anatomical representation of the patient, with including also the airway, because those surgical procedure they're trying to recollect and unifocalize the major aortopulmonary collaterals. This is the surgical correction 3D volume rendering. So the fourth type of shunting we can analyze with our imaging technique is the ventricular arterial discordant pre- and post-tricuspid shunt mixing. That is usually associated with one of the most important congenital anomalies, that is transposition of the great arteries. In this case, of course, the ventricular arterial connections are inverted, so the aorta is coming off the right ventricle, so the blood flow, the oxygenated blood flow is going into the aorta, and the partly oxygenated blood flow is going into from the pulmonary veins is going into the pulmonary artery. So, of course, these patients require a surgical correction very early in life, and they presented with severe cyanosis. And of course, the target of the treatment when the newborns, it is to increase the interarterial mixing by opening the interarterial communication if it is closed. Of course, the radiographic appearance of the shunting is a classical egg-shaped heart in the newborn patients. This is very difficult to diagnose without echocardiography again, but this is the characteristical appearance. Of course, we don't usually do neonatal TGA assessment with CT or MR, because actually they go early in life to the correction with the transposition and arterial switch. So they basically inverted the anastomosis of the aorta and pulmonary trunk and then they reimplant the coronary artery into the new aorta. So the most important reason we have to know this patient, because we sometimes have to follow them up after the surgical correction, of course, to investigate the coronary reimplantation site. So the CT is the gold standard evaluation for this patient nowadays in the early stage of life, again, when they are 4 to 5 years old. But they can do this also when they are grown up in the adult life, like as you can see here for this CT evaluation. Then I will conclude my presentation by presenting alternative way of instruments that we can use in our routine to evaluate shunting. So a few years ago, we published a study where we demonstrated that we can also evaluate the T2 mapping blood pool in signal and compare the left and the right blood pool signal to evaluate shunting based on the fact that the deoxygenated blood is presented with a lower T2 signal compared to the oxygenated blood. So in this case of suspected ARVC, the QPQS was one of the flow evaluated with phase contrast angiography, and the right to left blood pool T2 ratio was at 0.7, that is considered a normal ratio. In this other case, the right ventricle, left ventricle blood pool T2 ratio was 1, and the patient has a dilated RV with a QPQS calculated at the phase contrast velocity encoded MRI of 1.9. So if we don't have available flow evaluation in a uncertain condition, we can also take into account this opportunity to rule out shunting in case of a right ventricle dilatation. I just want to conclude with an interesting case, because we are facing with adult congenital patient treated many years ago, when we don't have details about the surgical correction, and when they presented to our clinic, and we sometimes have to scan them for a routine follow-up. And they are usually very complex case with arrhythmias and other diseases, so it's very difficult to scan. And this is a patient of 45 years old with the tetralogy of Fallot, where we have enlarged cavities with biventricular dilatation and with tricuspid regurgitation here. And this patient was very difficult to evaluate also the pulmonary regurgitation and to quantify tricuspid regurgitation, because the volumes were enlarged and was very difficult to differentiate the flow across this very turbulent and very complex congenital disease after correction. So this case presented after the MR with a QPQS of 2.6, so very high. As you can see, there was a turbulent flow at the level of the subaortic level. So we couldn't really visualize the VSD, but then we had the chance to evaluate in a second moment our 4D flow data that we acquired in this patient. and there was the possibility to confirm the presence of residual VSD at the level of the surgical patch, and this was, of course, in keeping with the residual connection after the many years after the surgical correction. Of course, this was causing also the left ventricle dilatation. Then the patient performed also a CT, and also in the CT where we were able to identify and localize the residual defect, and we also, this was useful to address the patient for an interventional cardiology treatment instead of reduced surgical. And then we can use anatomical images from our CT and MR. We can combine them and analyze with new softwares, as we know, to make them available for virtual 3D representation. And this is, of course, very useful to have a deep insight, understanding of different types of anatomies. This is a very interesting case where with a complex multiple VSDs, ventricular septal defect into a patient where we had all the different type of defect in the same heart. And this is, of course, very useful for the surgical to define the surgical or interventional approach, or combined or hybrid in a complex condition such this one. At last but not least, and of course this is this is not future, but is a reality in our center and in some other centers in the world. So we know that when we are evaluating our patient, we are missing some information. The main information is the pulmonary pressure, and the pulmonary vascular resistance is calculated accurately. And of course, to do this, we require catheterization, but with newer application and real-time imaging, we can do this in our MR setting and guide the catheter tip into the complex congenital disease to combine the data from invasive catheter evaluation, pressure and saturation with the flow calculated with MR to obtain an extensive and let's say complete cardiovascular evaluation in this patient before going for treatment. So having said that, I don't have a specific conclusion. I thank you very much for the kind attention, and of course I leave the space for question, remembering everyone that the next week we will have the annual ESCR meeting in Glasgow. Thanks so much.
Thank you very much, Aurelio, for this excellent and comprehensive presentation regarding shunt, from diagnosis measurements, but also to treatments.
Thanks so much.
2 questions from the audience. The first one is, which is the best tool for the blood flow quantification in shunts and aortic coarctation? So it's audio for you, Daniel. 4D flow or phase contrast 2D flow?
So what is the best for shunting?
Yeah.
Yeah, I mean, nowadays with tools and also for implementing our routine workflow, we can definitely say that and from the evidence in the literature, we know that the 4D flow is absolutely replacing in some certain complex condition the 2D flows, and this is of course an alternative way, absolutely valuable for the quantification of shunting. Of course, we can't really perform and acquire 4D flow in any patient, and I think in basic condition, in simple condition, aortic and pulmonary 2D flows, phase contrast is a well-established and standardized method to give accurate evaluation of shunting. Of course, we have to take into consideration that there are some, like in the last case, where some turbulent condition in which we have to consider to an optimal quantification of shunting to check and validate our shunting quantification with alternative flows. For instance, QPQS could be calculated alternatively with the IVC and SVC IVC flow, because this is actually, we know, is reflecting the QS. And so we can compare the aortic flow with the QS and the branch pulmonary arteries sum with the pulmonary artery trunk flow. So having a 4D flow available could give you the opportunity to give this, to have in one single acquisition all these alternative measurements to give the optimal result. And especially, this is especially useful for complex congenital disease and turbulent flows.
What about you, Daniel, regarding 4D flow and coarctation?
Well, the thing is with coarctation, you need a high venk to adequately get the. You need a venk that's higher than the actual flow in the coarctation, and that is going to affect all of the velocity you measure, unless you have a special sequence that where you can choose the direction of the high venk, and the other venk is going to be 150, and the one, and still you have to estimate, and then you scan for I don't know how many minutes. I very occasionally scan it, but it still is several minutes, like 6 minutes, 10 minutes maybe, and then for not so thin slices. And if then it turns out that you still have aliasing and you have to correct for aliasing, I'm already starting to not believe the numbers anymore.
Okay, thank you. No, yeah. Another question for you, Aurelio. Is there a cutoff value of T2 mapping ratio between right and left ventricle for a significant shunt?
Pardon, sorry again?
The question is there a cutoff value for the T2
zero,
mapping?
Yeah, of course, the numbers are very close. So this is still like 2 centers validation or 3 centers validation, sorry about that. So it's not like a large multi-center study. It's still validated, but the numbers are very, so the statistical results are very promising. 0.85 is suggesting a significant, but from limited numbers. So I will take this as a very carefully. It's 0.85 is a cutoff that suggests maybe I should repeat the scan and do some phase contrast on the aorta and MPA to make sure that this is not a big shunting. And of course, we are making a study and we realize that, of course, T2 mapping is not made for intercardiac evaluation. So the blood pool data should be sort of filtered by the flow. So we are making a study to sort of, but this is of course pure research, to produce a sort of filtered map for the blood pool that is of course based on the phase contrast in plane at that level of the T2 mapping evaluation. So that will probably make the T2 blood pool calculation more accurate. So of course those numbers have to be very accurate. So my message is, if the ratio is 0.7 and you are evaluating, for instance, a cardiomyopathies and there's a larger V, okay, you can rule out the shunting. I wouldn't consider that numbers to take a conclusion.
Okay. Another quick question. One participant says he's doing only cardiac CT for congenital heart disease, and he do calculate the QPQS ratio by comparing right to left heart stroke volumes. What do you think about this way? So I assume he's doing a multi-phase acquisition and he's calculating the stroke volumes of the two chamber. What is your opinion about that?
Yeah, maybe we can ask Daniel also about his opinion, but I think you can take this into account. Of course, we know that CT retrospectively ECG gated is a valuable tool in compared to MR for the volume calculation, and we use that in case of contraindication to CMR. So if there's a contraindication to CMR and we have a good echocardiography evaluation, we can have there's no valve disorder. If there's a big discrepancy in stroke volumes, I would, and we probably have some anatomical suspect of congenital shunting, such as pulmonary veins, atrial septal defect, ventricular septal defect, we can visualize that as well. I would probably take into consideration this number, but of course, this is not very well validated. So it requires expert analysis and a big experience. So I wouldn't really take a clinical decision with this data. Clinical and surgical.
Correct. Good. So it's 7 p.m. We reached the end of this webinar. I would like once again to thank you, both of you, for your excellent and advanced presentations on this not easy topics, congenital, and I hope, but we have a lot of good feedback from the audience. So once again, thank you very much. Thank you to our sponsor Circle, and thank you to Elena for the organization of this webinar. I hope to see you in Glasgow in next week. And for the rest, we continue to organize those webinars monthly. Thank you all and have a good evening.
Thank
Thanks,
you very
Francois.
much.
Good evening, everyone. Thank you.